So, however, as we all know, there is increasing trend toward organ preservation, right? In more so with bladder preservation approach now, and there is unmet need for an improvement in recurrences in patients who undergo bladder preservation approach. With bladder preservation approach, as of now, 5 years recurrence rate is nearly 40%, with distant metastatic rates of nearly 30%. Even in patients who achieve CR, recurrence rates remain nearly 20 to 30%. Cisplatin eligibility and ineligibility is one more concern in some patients, and there are some trials which have tried to establish immune checkpoint blockers as standard of care in some phase or the other. However, most of the trials with checkpoint inhibitors are with radical cystectomy more than Tri-Modality therapy. Based on the hypothesis that stereotactic ablative body radiotherapy or SABR boost adds to the CR rate and is reasonably well tolerated, it is hypothesized that Pembrolizumab as maintenance therapy in patients who have received SABR with conventional RT with chemotherapy and who have achieved CR, in such setting, Pembrolizumab as maintenance can improve PFS. So this trial was an investigator-initiated trial, phase 2, single site, with primary endpoint as PFS and secondary endpoints of OS, bladder intact EFS, and safety. With eligibility being primary bladder cancer, majority urothelial carcinoma bladder, ECOG 0 and 1 only, CT2 to T4, node negative, patients and who have undergone maximum TURBT and who are eligible or who are going to receive SABR boost with concurrent chemotherapy and who have achieved T0, TA or TIS post completion of treatment, which is assessed at around 12 weeks of completion of therapy with MRI and cystoscopy negative for residual invasive carcinoma. This is a small number for 54 patients who received Pembrolizumab as maintenance therapy. Plan was to give Pembrolizumab for 1 year as maintenance or 17 cycles, and follow-up was planned at 30 days after last dose and then 12 weekly survival visits. So the protocol was to do TURBT, then give stereotactic ablative body radiation with filled bladder, and add to then concurrently together with conventional radiotherapy 45 grain 25 fractions to pelvic lymph nodes with empty bladder. And concurrent chemotherapy used was weekly gemcitabine. Only those who achieved radiological plus cystoscopic CR received maintenance Pembrolizumab, and others proceeded for salvage radical cystectomy. So this was the schema of the things. Majority of the patients were male. Clinical stage, importantly, maximum patients, that is 85% are T2. There are no T4, T3 are 15%. TURBT complete was done only in about 40% of the patients, incomplete TURBT in nearly 60%. Concurrent chemotherapy, almost all the patients received concurrent chemotherapy. Surprisingly, neoadjuvant chemotherapy, only 20% of the patients received neoadjuvant chemotherapy. I don't know why. And majority of the patients did not have hydronephrosis. Median follow-up of 10 months. Only 10 participants completed 1 year of Pembrolizumab for some reason or the other. 1 year PFS was 85%, local control of 93%, OS is 97%. So, surprisingly, there are no grade 4 or grade 5 GI and GU toxicities, maybe because of the small sample size. 17 patients discontinued Pembrolizumab, 2 of the patients because of progression, rest of the patients because of one COVID patient died of COVID related death, and other patients received immune related toxicities outside pelvis. However, it is interesting to see because the initial papers on Pembro that was used concurrently with particularly with hypofractionated regimen, there were more toxicities with hypofractionation. This trial also used SABR, so it is a little bit awkward. As we can see, rest of the immune related toxicities are there. There is one severe hematuria, one immune therapy discontinuation because of death, 2 local recurrences, metastasis, myocarditis, cystitis, and pneumonitis as immune-related toxicities. So, if we look at the author's remarks that look like strength or opportunities, it is promising efficacy in early analysis. Immune-related AEs are consistent with what we usually see. There are some ongoing analysis of tissue specimen pending. However, if we look at the data from other checkpoint inhibitors, particularly with durvalumab with radiation therapy that analyzed everything right from the molecular profiling and peripheral predictable biomarkers, matches more or less with the nivolumab trial which was done on similar lines. So many questions unanswered, particularly where does this treatment stand in cisplatin ineligible patients? There are no details available. Small sample size, very short follow-up, no molecular profiling available at least till now, no peripheral markers assessed that can be used as biomarkers, did not include any node positive patients, did not have any T4 patients, does not answer the role of concurrent checkpoint inhibitors, if any, and of course it was a single center study, there is no comparative arm, and so for me it's not a practice changing abstract for now at least. Thank you so much.